So in the previous video, we discussed about how urine was formed, how the blood was filtered out by the nephrons, and how urine was formed. Now let's look at what is the fate of that urine that was formed, and some complications leading to it, as well as some hormones that regulate the reabsorption of nutrients in the urine. Now, after the formation of the urine through the formation and the collection of the urine, so once the filtrate has passed through the nephron and the collecting ducts and it reaches the renal pelvis, so that fluid can now be officially called the urine. So while in the renal pelvis, water can continue to leave the urine. So it is because again the reabsorption continues on. Now, because because water is being depleted, if the urine has a high salt concentration, so there might be a formation of the salt crystals. So the concentrating the salts in the urine forms these kidney stones. These are the salt crystals. So these are rock-like masses, usually composed of your calcium oxalates, and they can grow large enough to block the renal flow. And aside from that, it's actually these are basically rocks in your duct, so it is very, very painful and can cause a lot of damage. So in order to prevent the formation of the kidney stones, and even if you have one, remove those kidney stones, you need to drink plenty of fluids, so that again, in the first place, your urine has a lot of fluid, so it won't become too concentrated. So that is one of the cases for not developing the risk of the kidney stone formations. So from the renal pelvis, your urine travels down to the ureters to the urinary bladder. So the bladder is a hollow, variable-sized organ. So that means you can actually it's a collecting vessel for the urine. So it is lined with the transitional epithelium that allows it to expand. So that's why it's variable size. So it can expand without tearing or destroying the integrity of the inner lining. So discharging the urine from the bladder is called urinating, voiding, or more technically called micturition. So this is a reflex that involves both the smooth and the skeletal muscles, because again, this is like how the anal sphincter works. So you have voluntary control when you urinate or not. So, the micturition causes contraction of the walls of the bladder and the relaxation of the internal urethral sphincter. So, the external urethral sphincter is opened under our voluntary control. So, during micturition, the urine leaves the body via the urethra. The urethra is a single tube extending from the trigone of the bladder to the exterior. So, this is basically the view of your kidneys, the ureters, the bladder, and your basically down to the urethra. So the urethra carries the urine out of the body. So the urethra is a single tube extending from the trigone of the bladder to the exterior. So males have a long urethra, and it is used to carry both the urine and the sperm. Whereas for the females, it's relatively shorter and it only carries urine. So having a short urethra, that means that females have a high risk of urinary tract infection, or the UTI, because the bacteria outside the body can travel the very short distance, just the 5 centimeter distance, up the urethra to colonize the bladder. So this results in a painful urination, often accompanied by bleeding from the irritated bladder walls. So UTIs are serious infections that must be cleared up by usually taking antibiotics, because these are infections. You are fighting against bacteria. So antibiotics works there. So if the bacteria remain in the bladder, they will eventually travel up the ureters and colonize the pelvis and the tubules of your kidney. So the kidney infections are painful and serious because they can block the normal kidney function and can lead to kidney failures. If they reach the kidney, so they can clog up. These are bacteria that can clog up those very intricate, very delicate tubules, the renal tubules, the nephrons, and can cause a lot of damage. So incontinence is basically lacking of control in your urination. So incontinence occurs in all age brackets, genders, and social levels, but it is far more common in elderly women. So the causes include a chronic urinary tract infection, which side effects of medication, muscular weakness, an enlarged prostate gland for the males, constipation, or neuromuscular diseases. So we have 3 types of incontinence determined by the underlying cause of the problem. Each is the same result, which is basically incontinence. So for stress incontinence is leaking of the urine during a physical exertion. So you have a lot of, basically, your body is under a lot of stress. So you have the urge incontinence, the inability to quell the urge to urinate, and the overflow incontinence, which is the urinary bladder is basically overflowed. So you are waiting too long before urinating, so your bladder is very full and can no longer hold the urine. So you have overflow incontinence. So now let's look at how after we have done how the urine was formed and was expelled from the body, let's look at how the fluid and solute balance was maintained by the urinary system. So let's look back again at the kidneys. So the kidneys maintain the body's water and the salt balance. They remove the acidic and the basic substances from the blood. So we either excrete or absorb the substances in an effort to keep our blood volume relatively constant and our blood pH at roughly 7.4. So that is neutral pH, slightly basic. I mean 7.0 is the neutral one. So 7.4 is a very little bit basic. So the urinary system maintains the body's water-salt balance. So excreted urine usually has a much different osmolarity than the blood. So again, of course, because of the minute control of the nephrons, the reabsorption process of the different salts. So of course, the urine has a different composition than the actual blood plasma. But the urine can also be indicative of the composition of our blood through the if we can actually basically relate based on the normal average level. So anyway, so the dilute urine is produced by removing the solutes from the forming urine, leaving the nephron. So water does not routinely pass back to the bloodstream across the walls of the DCT or the collecting tube. So the ion concentration, so basically that the water is reabsorbed in the PCT, proximal convoluted tubule, and then even the descending line of the loop of Henle, whereas the ions are reabsorbed by in the PCT, again proximal convoluted tubule, and then the ascending loop of the ascending arm of the nephron and the DCT as well. So the ion concentration drops in the urine, the water proportion increases. So the fluid reaching the collecting duct is farthest concentrated than the blood plasma, resulting in a dilute urine. Because again, you are absorbing also the ions and the nutrients in your proto-urine. So concentrated urine is produced by the reabsorption of water at the loop of the nephron and the collecting duct. So the cells in the DCT can be controlled to reabsorb water by the presence of certain hormones. So basically, we can control how much of the ions is reabsorbed. Basically, control of the solute balance and the water balance of the body is being done in the DCT. This is the distal convoluted tubule down the after the loop of Henle. So the water can be reabsorbed across the walls of the urinary bladder. The reabsorption explains why the first morning urination is more concentrated than the urine produced and passed later in the day, because again, since the urinary bladder can store the urine of it also absorbs a bit of the water. The walls can also absorb a bit of the water from the urine. So, during when you're sleeping the night, so that's around say 5 to 8 hours, your urine sits there in the bladder. So there's a long sitting time. That is why morning urine is again very much concentrated compared to the other urine the rest of the day. So water can be reabsorbed into the bloodstream at the DCT and the collecting duct with the help from the hormone ADH. This is the antidiuretic hormone. So a diuretic increases the volume of the urine produced, whereas antidiuretic has the opposite effect. So, not only hormones has this effect, also some components in our diet. Caffeine is, if I remember, it's a diuretic. So, some drugs have diuretic or antidiuretic effects depending on the needs or depending on, well, basically their actions. So when you say diuretic, it increases the volume of the urine produced. That means it increases the water in the urine, whereas antidiuretic is it lowers the volume of the water in the urine. So diuretic can cause dehydration. Diuretic can cause dehydration, your antidiuretic is actually against dehydration. So it prevents you from being dehydrated. So ADH is produced by the hypothalamus and stored in the posterior pituitary gland, and is therefore it will therefore decrease the urine volume and increase the blood volume. So ADH prevents you from being dehydrated by lowering the urine volume. How does it lower the urine volume? It promotes absorption of water, or rather reabsorption of water from the protourine. So ADH in the blood causes the cells surrounding the collecting duct and the DCT to remove more water from the urine and returns it to your blood. So this is the feedback loop of your antidiuretic hormone. So we want to maintain a constant ion concentration. This is a normal ion concentration. However, what if you are, especially during the summer months, we tend to perspire often in our breath. There's a lot of water lost, breathing, and so the end result is that our bodies become dehydrated. Now, because of the dehydration, we have ion concentration of the plasma in the interstitial fluids. These are the fluids between the tissues, increases. So that means we lack water. So this is detected by the hypothalamus, and therefore the hypothalamus will now rather facilitate the release of your ADH. Now, the hypothalamus will tell your posterior pituitary gland to secrete the ADH, the antidiuretic hormone. Now, what is the action of this antidiuretic hormone? So, the antidiuretic hormone will tell the DCT to allow water to return to collect more water in the distal convoluted tubule. Why only the distal convoluted tubule? We are collecting water starting from the proximal tubule up to the end of the nephrons, but the DCT is the one where we have more control. The ADH control is at. So this more absorption of the water in the DCT. It makes your plasma more water enriched, and so more solvent. You have a decrease in the ion concentration in the plasma. So you will have a return to homeostasis. So your water is being conserved. So your ion plasma, the levels, the ion concentration which has become high, can return back to normal. So basically, this is your hormone feedback loop. Once it is normal, the ADH production stops. So other hormones and other chemicals can affect the salt regulation. So aside from the ADH, aside from water control, we can also control the ions that are being reabsorbed. So the hormones aldosterone, the atrial natriuretic peptide. By its name, it's natriuretic. So it has it helps regulate the natrium. Natrium is the old name for sodium. So atrial natriuretic peptide and the brain natriuretic peptide all regulate sodium reabsorption at the distal convoluted tubule. So this is for sodium ions. So the aldosterone, it causes the excretion of potassium ions into the filtrate and the reabsorption of sodium ions from the forming urine. So the water will leave the filtrate with the sodium ions and remain in the tissues of the body. Whereas ANP and BNP, they decrease the sodium reabsorption of the PCT, which decreases water reabsorption. So it reduces blood volume and the blood pressure. So ANP is produced by the atria of the heart in response to high blood pressure in the chambers of your heart, whereas BNP is from the brain. Now, they actually works in a reverse fashion. So aldosterone will allows for more excretion of the potassium ions into the filtrate and reabsorption of these ions back to the forming urine. So the end result is that sodium ions will remain, water will leave the filtrate with the sodium ions and remain in the tissues of your body. Whereas your ANP and BNP, it decreases water reabsorption of your in the flowing urine. Aldosterone is the different effect. So ingested chemicals can also affect the nephron function, such as caffeine and alcohol. Caffeine and alcohol are both diuretics that result in an increased urine production and may cause dehydration. That is actually, when you look at it in a different way, if you love to drink coffee, you become more diuretic, so you tend to lose more water because of the coffee, especially high caffeine or caffeinated coffee, and in response you have the urge to drink more coffee. So anyway, those are quite a more vicious loop. The same goes for alcohol. So you drink more alcohol, you have a high propensity to urinate, and then you also become dehydrated, so you want to drink more. So basically, those are some chemicals and their effects on your salt regulation and the urine formation. Now, aside from the salt and the water, kidneys also maintain the blood's acid-base balance. So, how does it do that? So, the body pH must be held within a narrow range. This is around 7.35 to 7.45. So, plus minus pH of 0.1. So, you have, they are done primarily through the bicarbonate buffer system of the respiratory system with help from the urinary system. So, you have your protons. Basically, this is your bicarbonate buffer system. So, your bicarbonate, this is bicarbonate, it can, if you have too much acid in the blood, the bicarbonate absorbs it, it becomes carbonic acid. And if you have, and it can further be, especially in the respiratory system, this carbonic acid can be released as carbon dioxide. So pH stability is achieved through this chemical equilibrium. The rate and the depth of breathing is in response to carbon dioxide levels in the blood and not oxygen levels. Actually, there was a hypothesis, I believe, that I've recently read, whereas yawning is actually a response to a high carbon dioxide level. So in yawning, it doesn't really signal you are sleepy, well, aside from that, but it also signals that you have a high levels of carbonic acid in your blood and you want it expelled. Well, that is what the article said, but I'm not, I'll take it with a grain of salt. So anyway, the carbon dioxide levels increase the blood pH, increase, then the blood pH decreases and the respiration increases in response. So through all the respiratory system is the main regulator of the blood pH, the kidneys also play a role. So for the kidneys, whereas the bicarbonate system uses an equilibrium reaction, for the urinary system, it can directly remove the acidic and the basic substances in the fluid by literally, of course, flushing them out. So if the respiratory system has to rely on the carrying capacity of the bicarbonate buffer system for our for the kidney system, or rather for the kidneys, they can just directly flush out the excess acids or even the excess space in our blood. So if the blood is too acidic, the kidneys can excrete hydrogen ions and send the bicarbonate ions back to the blood. Where if the blood is too basic, the kidneys will return the hydrogen ions to the blood and excrete the bicarbonate ions. So basically, those are homeostatic responses of the kidneys. So again, something like this one. So if to maintain a normal blood pH, if it's disrupted, for example, blood pH decreases and the blood is become acidic. So the kidney will excrete hydrogen ions to the urine, and because basically hydrogen ions are basically what causes our blood to become acidic. So it's directly thrown out to the urine, and so we will return back to the normal blood pH. The same goes for a basic blood. So if it's too basic, it will throw away the bicarbonate ions and reabsorb the hydrogen ions, so that you will maintain a constant or normal blood pH. Now, there are some, of course, diseases that can affect the urinary system. So, chemical analysis of the urine can reveal a number of serious diseases. That is why urine test is actually a very routine in physical examination, because the urine can tell us a lot. So, the urine is a byproduct of the filtered blood. So, any unusual compounds or incorrect levels of normal blood constituents will appear in the urine. So, abnormal components can include the albumin, hemoglobin, red blood cells, the white blood cells, the glucose, and CAST. So, which indicate a specific problem. So, these are the normal constituents of the urine and the different, basically, the parameters that are being studied, or rather examined in the urine. So, these are the different abnormal constituents of urine. I won't be discussing this one in depth too much, because again, this is more of a systems physiology. It's not basically a medical lecture, but rather more of us understanding how the body system works. So I'll just leave it to you to read on your own. So let's look at kidney diseases. So without functioning of the kidneys, blood composition cannot be maintained and homeostasis will be lost. So the three of the most common kidney diseases is nephritis, glomerulonephritis, and polycystic kidney disease. So the polycystic kidney disease among the three are the only one inherited. This disease causes the cysts to form in the kidneys and destroy the normal kidney tissue. So in severe cases, the patient may require dialysis or even a kidney transplant. So for nephron inflammation, so nephritis or glomerulonephritis are both inflammation of the nephron of the kidney. So what's the difference? Glomerulonephritis is the blockage for the renal blood circulation with subsequent swelling and shutdown of the nephron. So basically, we are looking at the glomerulus side of the nephrons. So glomerulonephritis, whereas nephritis is just a general term for the swelling of the nephron itself, the convoluted tubules, and then the loop of Henle, etc. So when the kidneys cannot filter the blood, the toxins build up and the blood becomes filled with metabolic wastes. The blood volume and the composition are disturbed and the patient becomes ill. So these symptoms include nausea, dizziness, fatigue, and memory loss. So if the iron and the fluid balance is not restored, that can result, because again, the kidney is very important in removing the toxic substances in our urine. So in our bloodstream, So if these metabolic waste accumulate, this is very fatal. It can have fatal consequences to us. So that is why for the cases where the kidney cannot actually function quite well, we have what we call therapy such as dialysis and the hemodialysis. So dialysis is the exchange of aqueous substances between the two solutions through a membrane using dialysis machines. So when the kidney is shut down, dialysis must continue somehow, or the blood will become toxic to the body cell. So if we have problems with our kidneys, we still need to be able to filter out the blood. That is why we have hemodialysis. Hemodialysis is between the blood and another fluid. Basically, we have hemo meaning the blood. So these are relatively common procedure used to compensate for the impaired kidney function. It may be done for extended periods, such as when the kidneys have failed and no matching donor kidney is available. Especially in the case of the kidney donation, you must have always a match, because donating organs, there's always the risk of rejection. So the immune system rejects the basically it's a foreign organ, a foreign material inside the body. So in the cases where kidney your basically kidney filtration is or rather kidney cannot function well, a machine must be able to take over the role of that kidney. So in hemodialysis, the blood is withdrawn from an artery and passed across a dialysis membrane. So toxins in the blood diffuse into the prepared solution, while the necessary blood plasma components, they are either prevented from diffusing by putting the same concentration of these components, or by or added into the blood through the by increasing the levels in the dialysis fluid. So this is actually quite difficult, because you must be able to know exactly the exact concentration that must be removed or added back into the blood. So in hemodialysis, the dialyzed blood is sent back to the body. So you are going to remove the blood from your body, run it to the dialysis machine, and then return it back to the body. So this procedure takes 3 to 4 hours and must be done 3 times a week. So hemodialysis is tough on the blood cells because they are passed through tubes and across membranes under pressure. So this causes basically rupturing of your red blood cells and causing basically anemia. Peritoneal dialysis is a procedure where 2 liters of dialysis fluid is put directly into the abdominal cavity and let to diffuse and then remove. The peritoneum serves as the dialysis membrane and must be performed daily to sustain life. So this is a different way of doing hemodialysis. So in some cases, the kidney is so diseased that it needs to be replaced. Kidney transplants are quite common, and we have 80% patient and organ survival rate after 1 year of transplant. But beyond 1 year, well, it usually goes down. Okay? So this is the end for the kidney treatment. So I will include additional videos, especially for how hemodialysis works.